All right. Thank you, everyone, for joining us today. My name is Brenda Goldhammer. I'm the Program Director for the National Clinician Consultation Center. Today, we are hosting with HRSA, Bureau of Primary Healthcare, our webinar on cannabis use disorder. We're very thrilled to be presenting today. As a reminder, we will be recording today's webinar and make the recording available to anyone that is registered for the presentation. There will be a survey. We would love to get your feedback at the end of our presentation today. And please feel free to use our chat if you have any questions for our presenter. We're very thrilled to have presenting for us today, Dr. James Gasper. He is a psychiatric pharmacist who focuses on the treatment of co-occurring disorders. He's a consultant for the National Clinician Consultation Center's Substance Use Warm Line. In fact, he's been with us since the very start of our Substance Use Warm Line. He received his Doctor of Pharmacy from the University of Colorado and completed residency training at the Denver Veterans Affairs Medical Center and the University of California, San Francisco. Before we launch into our presentation today, I would love to introduce Laura Chassaw, who is with the HRSA Bureau of Primary Healthcare, to tell us a little bit more about HRSA BPHC.
Thank you, and thank you all for attending, especially we had to reschedule. California isn't in a drought anymore, I think is maybe the best way to put it. And welcome to the Cannabis Use Disorder. We're very grateful to have National Clinician Consultation Center prepare this webinar and such a really important and timely topic. The Bureau is committed to leveraging our strategic partners and delivering the latest information and promising practices and supporting the work performed by our nearly 1,400 health centers. Before I turn it over to Dr. Gasper, I'd like to share just some information about our health center program here at HRSA and some initiatives we're working on related to behavioral health and SUD. Next slide, please. In 2021, HRSA-funded health centers continue to advance health equity by serving high proportions of patients from medically underserved communities. Health centers provided affordable, high-quality primary health care to more than 30 million people in the U.S. each year. This included 1 in 5 rural residents, 1 in 3 people living in poverty, over nearly 1.3 million people experiencing homelessness, and over 1 million agricultural workers. Next slide, please. During COVID-19 and the subsequent recession, the number of adults in the US reporting symptoms of anxiety or depression disorder has increased from 11% to nearly 41 to around 41%, and nearly all of our health centers provide mental health services, providing critical access. And in 2021, 2.7 million patients sought mental health services at our health centers, with 67% of patients 12 or older received depression screening follow-up through primary health care, which is an increase from 2020. We saw an increase of integrated behavioral care, and that included medical and mental health providers who do not specialize in substance use disorders providing SUD services. In 2021, over 50,000 non-SUD providers had over 5 million visits that included SUD services, which is exactly why the services of NCCC and the Warm Line are so important, because you are all treating patients who either are displaying some signs of substance use disorders or maybe wanting treatment for it, and just saying, oh, I will refer you to another provider is not always the answer, and the Warm Line provides a really critical bridge. And now I'd love to turn it over to Dr. Gasper for this presentation.
Thank you. And good morning, everybody. And I can't echo more what you just mentioned about access to SUD services and primary care. It's really the workforce that I think sees most of the consequences of addiction. And it's where patients show up, and it's where they have access, particularly at our FQHCs across this country. So glad to be speaking to you all today. And we're going to be talking about an interesting topic, cannabis use disorder. You may know it as marijuana addiction. They're one and the same. It's been around since the beginning of time, but it's certainly changed quite a bit with the introduction of commercial sale and various different approaches across the states. And we're going to talk about how that's impacted cannabis use disorder specifically. We're also going to dig into not just the onset and the incidence of it within the population, but also how the drug supply has impacted that directly. We're not going to have a whole lot to say about treatment, unfortunately, because we don't have good treatments for cannabis use disorder, but I will flesh out what is available more towards the end. I'd like to acknowledge our funder, HRSA, for our program, and let you know that there's nothing that I say is to reflect the views of the Department of Health and Human Services or HRSA. More to the point, I think it's worth mentioning that cannabis remains a Schedule I controlled substance, back to 1970, the Controlled Substance Act, and that hasn't changed since then. This does have some impact on research, and obviously there's some discrepancy between federal statute and the way the states have approached this. I'm not here to talk about legalization or decriminalization, but we are going to discuss how the commercial access has impacted the drug supply. Any medication that is used to treat cannabis use disorder is off-label. There's nothing approved, and I can tell you at the outset, there's very little evidence anything is effective. In some cases, I'll switch back and forth between marijuana and cannabis, and this is an artifact of the research up until 2012, 2013. We're really talking about plant. In the last 10 years, it's been transitioned into cannabis products as edibles and other concentrated forms have become available. So the research reflects that, and the nomenclature changes. And I'll flip back and forth, but I think you all know what we're discussing. Okay. So a little bit of background. This has been continually updating, but you can see by both the dark green and the light green slides here that there is some form of medicinal or recreational access in most states in this country, as well as territories. There have been a few additions to this in 2022 and some coming in 2023. But as of last November, this is essentially the scope. You can see that, our more liberal west coastal states have both medicinal and recreational access. And then there's a smaller number that have just medicinal use, and the gray reflects states that don't have either one. And there's some level of cannabidiol access in those places and other iterations of cannabis. Just as an aside, as Brenda mentioned, I did my training in Colorado, and Colorado's medicinal access dates back to about 2000. And at the time, I was in pharmacy school, and we had a very small list of patients in the state that had access to medicinal cannabis. And I was working as an intern in an oncology clinic. And I remember speaking with the oncologist about, placing patients on this registry. And his point was basically everything that marijuana can do, our medications, our prescription medications can do better. So he didn't really see a role for it. He also didn't necessarily disagree with patients at the end of life having access to it. But it was a very, restrictive list, which is odd, looking at where Colorado's today, being really ground zero of both medicinal and recreational access. So I kind of left Colorado and came out to California about 2004. And in California, the medicinal access dates back to 96, was well established. And essentially every patient that I saw in an SCD clinic had a card giving them access to it. So it was very widespread in the population that I was seeing. And something that concerned me was a lot of my psychiatric patients were taking prescriptions that I wrote for antidepressants or for psychostimulants and bringing that to the cannabis doctors to get their recommendations. So they're getting medicinal cannabis cards for indications such as ADHD and depression, illnesses that cannabis has no role in treating, and in fact makes both of those worse. There was a little bit of a conflict, and I had a hard time kind of discussing with patients some of these concerns that I had, and they essentially would wave their card in front of me and say, well, you know, my other doctor said it's okay for me to have this. And that was kind of the end of the story and the end of the conversation. So I didn't have a whole lot that I could say or do. There's been a lot of evolution, and I've seen that from a few different states' perspectives. All of that really changed about 10 years ago when recreational access, adult access came. 2012 was Colorado and Washington State, and it just kind of spread since then. And you no longer need to go through this process of even a medical screening to access it. So it's pretty widespread. You can see that in these dark green states. So I've been able to see it from a few different perspectives, and I'll tell you kind of along the way some of the problems that have come with that. One of them is, this is probably a big take-home point. If we look at THC concentration, it's changed a lot over time, and this doesn't correlate with medicinal and recreational sale in states necessarily, but we can say this is whole plant THC concentration has really been on an upward trajectory since the mid-90s. And if you go back further, you know, the 70s, it was in the 3% range. Today we're looking at edible cannabis products with close to 17% THC. And this is just plant. This does not reflect the vape products or the edibles, the number of other formulations available in retail sale, which also have very high THC concentrations. So if we just look at plant, there's been a steep increase, particularly in the last 10 years. And along with that, we've had an increase in emergency department visits. And I can say, you know, after showing up in California as the dispensaries were kind of coming online, for the first time in history that I had seen, people were coming to the emergency department with psychotic episodes, panic attacks, things that we didn't see with the lower potency products, you know, dating back into the 90s. And this data reflects it. The other drugs was fairly, you know, stable throughout the time period, but we had this somewhat linear increase in marijuana ED visits while the concentration was on the rise. There was also something else that happened, which is that if you ask 12th graders how they felt about the risk of marijuana, and you looked at their actual use, we had somewhat of an inverse relationship. We can see, and this is probably no surprise to anybody here, that going back in the 70s, the perceived risk for marijuana was very low. And in fact, the risk of the drug was quite low when the percentage of THC was in the single digits. And there was a slight increase in perceived risk in the 90s. I'm guessing here, but it's probably at the time that the, you know, Dare to Say No campaigns were kind of at their peak, and, you know, people were somewhat resistant to the idea of any illegal drug. But that quickly fell away as we got into the late 90s and the 2000s, where the perceived risk was on a decline. And the inverse relationship was there was an increase in past year use of marijuana at the same time. So a lot of this correlates with the introduction of recreational and medicinal access across states. Risk has gone down, past year use has gone up. And we know for a fact that if you look at adolescent use in states that have these types of commercial availability, that there's almost a doubling in their use of cannabis. Okay. Just to define terms, the diagnostic criteria for cannabis use disorder is the same as it is for every other substance use disorder. You have to have at least 2 symptoms in the past 12 months, and we're really talking about loss of control over intake and negative consequences. So it's no different than any other substance use disorder, and severity correlates with the number of symptoms. So if you have at least 2, you're looking at mild. You add on, I believe it's 3 or 4, it's moderate, and then 5 and above would be severe use disorder. in the birth to 30-year range, the first of incidence of cannabis use disorder seems to be the highest around 18 years of age, but there's clearly an onset in late adolescence and the teenage years. And that's a problem because if we look at the risk of schizophrenia, it's a concern for exposure prior to this 18-year-old, 18 to 20-year age range. So we have kids that are using cannabis. We have kids that are being diagnosed with cannabis use disorder at an age that is critical for subsequent onset of schizophrenia. So we have a lot of use in this age group. And again, these are first incidences. And you might question what that means. So you can have multiple episodes of cannabis use disorder. Essentially, it takes 2 years to develop the diagnosis and then 12 months without use or without meeting the criteria to be in sustained remission. So that would be one episode. You can have multiple incidents of cannabis use disorder in this range. This is just looking at the first age of onset of addiction. We're talking about cannabis addiction. Looking at the prevalence, and this is a community sample, so this is all comers and the under 30. We're looking at roughly 1 in 5 males, a little bit lower on the female side. It's a pretty high percentage. I mean, this is on par with lifetime prevalence of something like major depressive disorder, so it's fairly common. Average age of onset around 18, about the time that kids go to college, no surprise. The good news is that recovery is quite substantial by the age of 30. It drops off very quickly. So we're looking at about 80%. And going back to the different cannabis use disorder episodes, it takes about 3 years to go through this cycle. So when somebody has the onset and they meet criteria, another 2 years, they're out of that window and they're in sustained remission. So recovery is fairly quick. Most people are recovered by the age of 30, and it's predominantly in males. Looking at this another way, again, this is looking at lifetime. We're looking at adults, so greater than the age of 18. How the distribution is mostly in males. Look at this peak in age. It's in that 18 to 30-year range. It's also where the most severe cannabis addiction exists. We can see that it drops off fairly quickly in the 30 to 44 age range. And by the time you get to 45 and up, there's almost no severe cannabis use disorder, and the overall percentage or the prevalence of it certainly is much less. So we got this early peak, predominantly in males, and pretty much drops off, after the age of 30. In older adults, and this is just cannabis use, and just based on the data, we don't have addiction data in every age group. Sometimes we're just looking at use, which is usually 30-day past use from community samples. If you look at the group over the age of 65, cannabis use is about 3%, so it's fairly low, and this doesn't imply that they have any problem with it. I do have some concerns with older adults being exposed to cannabis and its effect on cognition, which would be separate from actually having a cannabis use disorder per se. But the overall incidence is quite low as we increase in age. Now we're going to talk a little bit about some special populations, and one of those germane to our conversation today is people living with HIV. In terms of onset and the risk period, it looks almost identical as it does to the general population. So for people living with HIV, the highest risk period is in that 18 to 30-year range, and it's predominantly in males. Something to keep in mind is that if somebody screens positive for use of cannabis in those living with HIV, almost half of them will have actual cannabis use disorder, which is much higher than community samples. So this cohort is at an increased risk of having actual cannabis addiction if they use cannabis. And if we look at how that impacts their treatment, adherence is not as good. There are more symptoms and there's more side effects from their medications. And, part of my experience in California working with people living with HIV was that there was pretty much carte blanche access to medicinal cannabis. It was being used for HIV-related neuropathy or for appetite stimulation. These were fairly common indications for it. And you can see that this was not necessarily a safe drug to have available to patients that have HIV. So we really don't want to overlook it in this population. Something that I've been faced with, and many of you have along the way, is the comorbidity. There's a number of things that come with cannabis use disorder, and that's often the presentation, right? So patients don't show up and say, I'm worried about my marijuana use. What we see is other psychiatric conditions, other substance use disorders as being the predominant presentation. And really the trifecta is alcohol, nicotine, and marijuana. I think everybody would agree that's a fairly common presentation for patients that have really a polysubstance use disorder, and cannabis is just one of the drugs that they're exposed to. And the odds ratios are very high for this comorbidity, and we're often faced with treating, multiple substance use disorders. We also have a lot of psychiatric comorbidity, bipolar 1 being the psychiatric illness that has probably the highest incidence of other substance use disorders, and cannabis is no exception for that. We also see a variety of anxiety disorders and personality disorders, and I can tell you that it's very difficult to stabilize psychiatric conditions in somebody that's using cannabis on a daily basis. And again, the conflict here is in states that have medicinal access, that may be the actual reason that they were given the card. So from their perspective, they're using cannabis as some form of treatment, when in reality, it's probably making their psychiatric condition worse. So it's a very difficult conversation to navigate as we're trying to stabilize their comorbid psychiatric condition. Probably even more to a point is looking at psychotic disorders. So the adolescent onset certainly brings with it this doubling risk of schizophrenia, but also if we look at, lifetime cannabis use, and this isn't cannabis use disorder, but lifetime cannabis use, as you increase in severity, and these categories reference DSM-4, and we still had abuse and dependence, but these really just correlate with severity of cannabis use disorder. As you increase in the risk of, or as you increase in severity of cannabis use, the odds ratio of having some psychotic disorder also increases up to the point where the more severe cannabis dependence, we're looking at over 3.5 times the risk of a psychotic disorder. And something that's, again, very difficult as somebody with schizophrenia that uses a drug like cannabis on a regular basis, they often fit into this treatment-resistant category. And we really struggle with controlling their psychotic symptoms in the face of cannabis, in particular, the higher potency formulations that are available through retail sale nowadays. Again, special population, we talked about adolescent onset, but what are the consequences of it? Something that's really concerning to me is that if you look at just cannabis use in adolescents, they are at a higher risk of having depression, suicidal ideation, and suicide attempts. And again, we get stuck in this corner. I know in California, adults 21 and up have recreational access, but believe it or not, kids can get medicinal access if they're age 18 and up with a doctor prescription or a recommendation. So in some cases, we have a system that permits kids to have access to this at younger ages, and we can see that there's very deleterious effects on their mental health. So they may be accessing cannabis medicinally for something like depression, but it actually puts them in a higher risk category for experiencing these symptoms. And, there's probably a chicken and egg scenario here as well. There's a selection bias towards those that may be at higher risk for having these symptoms to begin with. But when you compare it to those who aren't using, depression, suicidal thoughts, as well as attempts, is certainly a higher risk that we need to consider. Along with particularly the commercial cannabis industry, we've had a lot of concern with pediatric exposure to the edibles. And these products, they come in packaging that is not necessarily, I would say, child-proof by any stretch of the imagination. In some cases, it looks like candy or other products that kids, may be buying from convenience stores like gummy bears or chocolate or cookies, things that to them are familiar, that now have fairly high doses of cannabis in them, and their pediatric exposures to these edible products are almost non-existent before the retail sale. And you can see just in the last 5 or 6 years, the number of cases has tripled. And kids, the more likely to experience CNS depression, overexcitation. And I haven't heard about a whole lot of deaths, but certainly there are kids that have had severe toxicity from edible exposure, and they've ended up being intubated in the hospital. So we need to do something better to protect them from exposure to the supply. And a lot of it comes down to just the availability of edibles and how they're being stored in the home and how they're being packaged and how they're being marketed. Another group that we probably all run across is pregnant women that are using cannabis for a variety of conditions, including their mood, nausea and vomiting associated with pregnancy, as well as just the persistence of the use disorder itself during pregnancy. The exposure in utero is about 10% of the level the mother's ingesting. And we know that there are some developmental concerns. It's probably not teratogenic, but if we look during the early stages of development, there are some intellectual learning disabilities as well as a higher risk for autism. But something that we all should be familiar with is the concentration of THC in breast milk because of the lipophilicity of the drug. It's actually 8 times the maternal level, so it's concentrated in breast milk, and it doesn't go away very quickly. We're looking at up to a week that it remains in breast milk. So the typical approach of pumping and dumping, as we do for things like alcohol, is not going to work for marijuana. You can get away from the peak of it, but it's still going to be concentrated in the breast milk, and the newborn's going to be exposed to it. Okay, so covered kind of the drug supply and some special populations. And now we're going to talk a little bit about cannabis pharmacology, which I can tell you as a pharmacist is kind of a challenging area because it seems like the more we study it, the more we realize how complicated it is. There's about 120 phytocannabinoids in the plant. Most of the research is done on isolated components such as delta-9 tetrahydrocannabinol or THC, but really there's an entire plant with a lot of different psychoactive compounds that we've just begun to scratch the surface of. And we'll talk about kind of the primary constituents for simplicity. As I said, the primary psychoactive component is THC itself. The primary non-psychoactive component is cannabidiol or CBD. This is available as a prescription product at Pedialex for pediatric seizure disorders. It's also widely marketed for a variety of conditions from pain to sleep and available in states that don't have recreational or medicinal cannabis authorization. So there's a lot of CBD products out there, and it is combined with THC as well. And some of the other commercial products. In terms of the pharmacology, the primary pathway that we're looking at is THC acting probably as a partial agonist on the CB1 receptor, which is widely distributed in the brain. And CB1 is a G protein coupled receptor that's primarily inhibitory on neurotransmission. The CB2 receptor is more in the peripheral nervous system and immune cells, as well as other parts of the body. We know somewhat less about it. It's probably not linked to any of the psychoactive effects. And just going back to CBD, it doesn't have any affinity has very poor affinity actually for any cannabinoid receptor, and whereas THC is predominantly binding to CB1. It wasn't until we isolated THC about 50 years ago that we even discovered the endocannabinoid system and found out what the endogenous cannabinoids were, anandamide and AG2. So we're really just starting to learn about this complicated system in the body, and you may wonder, why does it exist? What does it do? From what we can tell, it probably helps us to establish homeostasis, whether it's through regulating our body temperature, or through our sleep cycle, or through our appetite and our caloric ingestion. It helps to keep the organism in homeostasis, and it's pretty much the extent of it. So we have a complicated plant with a lot of phytocannabinoids that impact a pre-existing system in our body, and we're just learning about both of them. That's really where we're at today. So the pharmacokinetics are pretty well known for the products that are either smoked or vaped. About a third of what's in the product is delivered into the blood. The Cmax comes very quickly, so the maximum concentration is achieved within 10 minutes. So it's a fairly quick onset, and it lasts for about an hour and a half acutely. This is important because for people that are using cannabis products, they're able to adjust their intake. And we often don't see a lot of toxicity with somebody that's smoking marijuana because the fast onset of effect, it helps to regulate the intake of the drug. On the other hand, the oral products have slightly lower bioavailability, but a delayed onset of 1 to 2 hours. And in most cases of toxicity, we're concerned about that delayed onset because somebody may overshoot the mark. They may not feel the edible's onset, and they may take additional product after their first exposure, and this can lead to pretty severe panic attacks and even in the most severe cases, psychotic symptoms. So how's the active component broken down? Well, our parent compound, as I said, has a half-life of about an hour and a half. The active metabolite is a hydroxy THC, which has a slightly longer half-life, and that's further broken down into carboxylic metabolite, which is inactive. The reason I'm talking about this is what we look for in urine. So whether it's a drug screen, done in the office for somebody that's using substances and we're kind of monitoring their progress, or it's for job placement. All the screening tests look for this carboxylic metabolite, which stores in adipose tissue, and with chronic use is present for up to 3 weeks. So this is usually what we're looking at. It's also what we monitor in studies for marijuana withdrawal states, or for other assessments of exposure. We're always looking at carboxylic metabolite, which is inactive, but is a marker of recent THC exposure. Okay, so now we're going to get into the treatment. We're going to start with, we're going to look at intoxication, withdrawal, and eventually maintenance. And these are the different phases of cannabis exposure that we need to consider in terms of selecting treatment for And we're also going to talk about what cannabis intoxication looks like, because we haven't covered that yet. It's pretty much dose dependent and as well as body weight dependent. So the low to moderate dose exposures that we typically see, bloodshot eyes, increase in appetite, it can be sedating or activating, depending on the circumstance and the individual's past experience with cannabis. So this happens at a dose. If we normalize this for body weight, we're looking around 10 milligrams of oral product, which is what most of the edibles come in at. If you look at the retail availability of cannabis, it's in this low to moderate dose range of 10 milligrams per dose. In some cases, it's 5. The high dose range is about double that. So we're looking at doses of about 20 milligrams of oral. And that comes with some further side effects, things that are less desirable. It can get into being kind of a mild hallucinogenic. And in fact, a lot of people classify cannabis as a mild hallucinogenic. There can be vomiting, there can be an increase in blood pressure, as well as some other more severe side effects. And then, of course, the kind of the frank psychotic reaction of fear and paranoia and dysphoria is most likely to occur at the higher dose. But we can see this even in lower dose category for people with a predisposition to having psychotic symptoms. So it's dose related. Higher doses come with more side effects. And getting back to the pharmacokinetics, it's harder to regulate intake of oral product because of the delayed onset, and people can overshoot the mark and end up in this higher dose category. A lot of this is mediated by exposure. So somebody that uses on a daily basis consistently is more tolerant to the side effects, and they actually do a better job of regulating their intake. So we don't see as many problems. But somebody that's naive may end up with a high dose exposure having a lot of adverse effects, and we see them present to emergency departments with acute panic or with paranoia. The management is primarily supportive. Thankfully, the duration is fairly time limited. It's longer with the oral product because it's continuing to be absorbed from the gastrointestinal tract. But we're looking at only a matter of hours before things start to kind of wane. A little bit of benzodiazepine can go a long way, and that's going to be your go-to treatment for acute intoxication. And it just takes a few milligrams of lorazepam or the benzodiazepine of choice. In some severe cases, we may use an antipsychotic, and typically a small dose of oral haloperidol or an atypical does the job, but we rarely have to get to that point. Lorazepam or another benzodiazepine does the majority of the work. And again, it's time limited, and it goes away as the drug wanes. Something that we're increasingly seeing and being concerned with as the THC concentration has increased in the last 10 years or so is the cannabis withdrawal syndrome, which is becoming quite severe. For somebody that uses on a daily basis, roughly half will have some withdrawal syndrome. And really, I can tell you that we mostly see this in institutional settings. So somebody that uses marijuana on a daily basis and has consistent access to it doesn't stop using, we don't see withdrawal. If we bring them into a residential setting for treatment or into the hospital for a comorbid condition, and they no longer have access to cannabis, that's when we start seeing the onset of cannabis withdrawal, and it is not pleasant. Anxiety, irritability, changes in sleep, loss of appetite, a lot of these things come very quickly, followed by depressed mood and aggression and anger further down the road. But you can see that we're looking at roughly 50% of people that are chronic daily heavy users having some type of withdrawal symptom. And you might be asking, what can we do about this? Here's just another look at the timeline. The green shows kind of the deterioration in the carboxylic metabolite over time. And we can see there is a persistence up to about 3 weeks out, with different stages along the way, with an onset in the first couple of days, a peak around a week, and then this kind of longer tail as the carboxylic metabolite leaves the system. But getting back to management, really the first thing to consider is what else are we looking at a withdrawal state from? As I said previously, a large number of individuals who use cannabis also use other substances, in particular nicotine, alcohol, and you can pick your other drug, whether it's opioids or stimulants. They often get thrown in the mix. And we have pretty good drugs for withdrawal states from a number of those, and it's important that we treat them, because you can imagine withdrawing from nicotine and marijuana simultaneously is going to not only make it more difficult to manage, but there's a lot of overlap in the symptom presentation. Same thing for alcohol or other CNS depressants. So we need to address the comorbid withdrawal state. Any of the symptoms we can attack from kind of a symptomatic standpoint, whether it's using something like trazodone for insomnia. We don't often like using benzodiazepines in somebody that's withdrawing from other substances, but they can go a long way for treating anxiety, particularly in the supervised setting. So we can do some things for the symptomatic treatment of withdrawal, but at the end of the day, cannabinoids are the most effective treatment. And this is the reason that we don't often see cannabis withdrawal in the community setting, is that our patients actually continue to use. So before they start to feel sick from withdrawing, they're able to re-up on their supply and they continue to use, and it remains kind of fairly silent. So this is a bit of an artifact of bringing people into institutional settings where they no longer have access to cannabis that we see this the most. But even there, cannabis is going to be the most effective treatment, or any cannabinoid, and we do have some prescription products that are effective for withdrawal states. And we'll get to them in a second as we talk about maintenance treatment. So maintenance, by definition, if we use like the opioid agonist approach, our goal is twofold. One is to decrease relapse, so if we want people to not be using any cannabis product, and also treatment retention. We want them to stick around so that we can continue to provide service to them and manage comorbid conditions, whether it's psychiatric or medical, et cetera. So those are our primary outcomes. We did have a fairly recent systematic review and network meta-analysis, and the network meta-analysis just means there's more indirect comparisons than direct comparisons. It's just another way of combining data. 24 trials. So these are 24 individual drug trials with about 2,000 participants that looked at pharmacotherapy for the treatment of cannabis use disorder. And again, our primary outcomes were reduction in use and retention and treatment, or at least that's what these authors looked at. And I'm only presenting the positive findings, or those that differentiated statistically from placebo. If we look at the outcome of cannabis use, so this would be return to cannabis use in somebody that has cannabis use disorder, there were 3 drugs that in the random effects model showed an advantage over placebo. I believe there were 5 additional drugs that did not. So again, I'm just showing you the specific list of those that separated from placebo and then network meta-analysis. The first one is nabilone. I don't know if anybody's heard of it. It's Sesamid. It's actually a prescription product. It's a synthetic THC. Interesting thing about it is it doesn't get metabolized see the carboxylic metabolite. So we don't see this on UTOX. If somebody was prescribed nabilone, it would not test positive for THC because it's an analog of it. It's a semi-synthetic analog. Actually, it's a fully synthetic analog. And it did show some advantage in cannabis use. Doses were quite high, 8 milligrams, and this is usually prescribed in the 1 to 2 milligram range, so it's much higher than what we would see in practice. But I can tell you, I believe the indication is for nausea and vomiting associated with chemotherapy. I've never seen this prescribed. It's a C2. It's a very potent drug. Most patients prefer to smoke cannabis over taking oral products, particularly oral cannabinoids, because it's hard for them to control their intake of it, and they get more of the adverse effects than they do any of the desirable effects. So we just don't use a whole lot of this. Topiramate, the anticonvulsant, also showed up as differentiating from placebo on cannabis use. In a second, I'll tell you that there are some problems with using topiramate in this population, but in this case, there was a positive finding there. And then lastly, the FAAH inhibitor, which is the fatty acid amide hydrolase inhibitor. It's not commercially available, but a drug that's been studied, which inhibits the metabolism of the endogenous endocannabinoid anandamide, which would increase tone in the endocannabinoid system. Also seems to have a positive effect on cannabis use and those with cannabis use disorder. Looking at treatment retention, the other prescription product, dronabinol, which is Marinol, does have some advantage in keeping patients in treatment, and that's maybe because of its efficacy in treating the withdrawal state. Whereas topiramate actually fared worse in terms of treatment retention, and that's probably no surprise to anybody here. It's not a very well tolerated drug. Depending on the dose and the titration, there are a lot of adverse effects that come from topiramate that could cause patients to actually drop out of treatment and not prefer it. This was, in the network meta-analysis, I think there was 19 other drugs that didn't differentiate from placebo. So I'm just showing you the two that did, but again, there's roughly 20 other ones that showed no difference. And that's pretty much the story when it comes to looking at treatment. We've studied a large number of drugs in fairly small studies, and very few of them have shown any real benefit. A quick summary of some of the other findings. So the network meta-analysis wasn't designed to look at these outcomes, but there were some other notable findings that we'll dig into. Gabapentin seemed to reduce cravings, and cravings is a surrogate marker for relapse, so that's good. And it's also a drug that most patients can tolerate and we're fairly comfortable with prescribing. It's not a controlled substance in most states, so access and availability is also not much of a concern. Vilazodone actually worsened cravings. Buspirone, Effexor, and topiramate came with side effects, and then again, topiramate also had more dropouts. So most drugs either did nothing or they caused some problems. So we don't really have a lot of consistent findings for many intervention, unfortunately. Looking just at agonist treatment, so these are all prescription drugs. Dronabinol again, and nabilone being available in the United States. The Biximols is Sativex. It's not available here, but at the THC CBD combination, sublingual spray in Canada and in Europe. There are some benefits from these products, typically at doses that we don't prescribe. And I just want to say we don't prescribe these. There's very limited use of them. Even when we've tried them as I mentioned earlier, patients don't like them. They'd rather have access to the delivery system of, choice, which is usually smoking cannabis or vaporizing it. They're not looking for an oral product. And coverage by third-party payers is inconsistent, questionable whether it's even legal to prescribe a cannabinoid for a cannabis use disorder. There's a lot of problems here, and the dosing is off the charts, and it's something that I wouldn't be comfortable with. In most studies, the effective dose for something like dronabinol is in the 60 to 80 milligram range. Typically, use of it for nausea and vomiting associated with chemotherapy or appetite stimulation is, 15 milligrams per day or 5 milligrams TID. So the dosing of these is extremely high. Same thing for nabilone. 3 to 4 times what we would use for the actual FDA indication. There is some benefit on withdrawal symptoms in most cases, in addition to other medications like lofexidine, which is an alpha-2 agonist, or zolpidem, the sedative, doesn't have a consistent benefit, but it has been studied. The most broad spectrum effect is from nabiximols, which is the combination of THC and CBD, but again, it's not available in the United States. So there is some benefit from agonist treatment. We're probably never going to be in a position where we're going to prescribe any of these, nor are they ever going to achieve any of the indication, and the dosing is quite high. So practically, this is not a useful group of drugs, but there are potentially some benefits, and particularly in withdrawal symptoms. I do want to just spend a second looking at gabapentin. It didn't fall out in the network meta-analysis, but if we look at just one of the individual studies, it doesn't look too bad. So the dosing is about the same as we use for alcohol maintenance, 1,200 milligrams a day, which is a fairly well-tolerated dose for most patients. Regardless of the indication, whether it's for alcohol or for pain, for anxiety, whatever the case may be. In this study of about 50 participants, there was a decrease in cannabis use. There was an improvement in withdrawal symptoms. And that's pretty much what we would hope for from any effective intervention. So again, we have a fairly well-tolerated drug that does have some positive effect on use and withdrawal, but this is just one study and it hasn't been replicated. So there's clearly more work that needs to be done here, but there is some promise. If we just look at the graph compared to placebo, we can see that the days of marijuana use over the three-month period decreases, and there is a separation from placebo. So it's promising, but it's also preliminary. And I'd like to see some more consistent research with it before we could endorse it. But it's not a bad option in that regard. So what else can we do? I was thinking about harm reduction, because let's be honest that patients rarely come to us asking for treatment for their marijuana addiction or for their cannabis use disorder, but there's things that we can share with them that could minimize the negative impact, which could be using lower THC concentration products to avoid some of the higher dose adverse effects. Similar to that would be to decrease their exposure through less deep inhalations or not inhaling at all, but in some cases switching to safer administration pathways, which could be the low dose edibles, et cetera, as long as they control their consumption of them. If we want to avoid the risk of withdrawal state, avoiding daily use or high dose exposure in any formulation would also be an important intervention. Something else is to use the commercially available products. So depending on the state, there's a lot of regulations that go into how something like the edibles are produced and the quality control. And that comes with a certain amount of consistency in the drug that's being delivered. So using them can be advantageous as opposed to a cookie or a brownie, some other product that is baked at home where the concentration of THC is unknown and may vary widely from batch to batch. Having access to a consistent quality controlled supply can help patients to manage their intake. Obviously, there are a number of risks with cannabis consumption while driving or engaging in other high-risk activities. So that's probably something best avoided. And we can kind of reinforce that with patients that it's not safe to consume cannabis, just like alcohol, while driving or using machinery or riding a dirt bike or wherever the case may be. Combining with other psychoactive substances, including alcohol, comes with its own problems. So we don't want people to be mixing cannabis with other drugs if all possible. And something that I often come back to is in our psychiatric patient population that had pre-existing psychosis or bipolar disorder or at high risk for having an addiction, we really want them to avoid or limit the use. So in some cases, the use of cannabis is not really appropriate. Also, the harm reduction is moving more towards the abstinence phase. And this is something that I see a lot in those that have had an exacerbation of their psychotic symptoms from the cannabis exposure. That's really a scenario where we do want to move patients more towards abstinence, away from it, because any exposure to cannabis may be problematic under those circumstances. So just to put kind of a fine point on what we talked about today, things have been changing in the United States with the retail sale of the products. It's impacted the THC concentrations. It's impacted the way that society perceives the risks of cannabis, and there have been some negative consequences along with, from my perspective, more cannabis use disorder, particularly in our adolescents at earlier ages, and a net exposure to higher concentration products. That's been a big concern, and it's been an evolving trend, and it probably will just continue along that pathway. In terms of treatment, we've looked at a lot. Again, the studies are small. There hasn't been any consistent findings. I don't think that we're confident in saying anything really works. There may be some promise for medications like gabapentin, but we do need to have more studies on that. And there are some benefits from oral cannabinoids, but that's just not a practical intervention, really, for a number of reasons. Patients don't prefer them. We don't have routine access to them, and a lot of people just aren't comfortable with the doses that are required. So this is something that we're still in the process of fleshing out, really, how best to approach cannabis use disorder. And I'll just show you, this is who we are. We don't just talk about substance use, but we have a variety of other lines for your access, whether it's on hepatitis C, HIV, pre-exposure, or post-exposure prophylaxis. So please call us. We're here for you. And back over to Brenda.
Thank you so much, Dr. Gasper. We actually have a question in the chat. Patty is wondering, are vitamin supplements or Benadryl recommended to aid in withdrawal symptoms?
There's no benefit there. If we looked at diphenhydramine as a sedative for insomnia, potentially, but tachyphylaxis develops quickly within a few days, so it's not going to last very long. You're also not going to do a whole lot of harm with antihistamine, but it's not going to have any benefit. And there's no vitamin supplement that does anything for withdrawal symptoms.
And we have a comment, running or high intensity workouts increase endorphins, which also help for people trying to quit marijuana use. I don't know if there's any research that we've seen looking at, for example, quote unquote, the runner's high, and helpful for as being helpful for trying to quit marijuana use.
Not directly. I can say that exercise and lifestyle modifications can be a cornerstone of recovery as we move patients towards more positive health behaviors. And substance use is just a negative health behavior. So if we are more focused on positive health behaviors, whether it's diet or exercise or meditation, there will be some benefit from it. Is it specific to cannabis? It's not. It's more generically beneficial to psychiatric and substance use disorders.
And maybe just our last question for the day, Dr. Gasper. Maybe you could talk a little bit about communication strategies, particularly for some of our individuals on the line that may be managing patients who have comorbidities or neurological issues such as ADHD, or treating mental health issues such as anxiety.
This is something that I've been carefully navigating for a number of years. I kind of alluded to it. My group of patients that have medicinal access for the psychiatric condition that I know is making it worse. We don't want to be in a situation where we're arguing with somebody about their substance use. We just need to consider the disconnect between what they're doing and how they're presenting. So when somebody's having persistent symptoms of their psychiatric illness, and we've made multiple attempts at managing them with medications and with psychotherapy, and we see that that's not working, we need to start looking at other reasons for it. And it's best to get patients to kind of come to that conclusion on their own. If they say, I'm having anxiety, or my distractibility is worse, my mood isn't good, my sleep is not where I want it to be, then we can start kind of bringing in the conversation of how cannabis is not necessarily happening. And this isn't so different from what we see with alcohol or with stimulants or other drugs of abuse. The unfortunate reality is that as the stigma of using cannabis has gone down, patients don't even think about it. It's not even on their radar. So that has to be the beginning of the conversation. It's like, hey, you're using a marijuana product on a daily basis. We have these symptoms that we're having a hard time wrapping our head around. How are these two related? And kind of helping patients to come to that realization on their own. It doesn't go well when you just point it out, because in their head, they're not seeing it the same way. They see it as some, medically endorsed, recognized product that is supposed to be benefiting their symptoms. So it's going to be a little bit of a surprise at first. So you have to kind of work into it slowly, and it may take multiple times of communicating it with the patient before they even begin to see how their cannabis use could be negatively impacting their psychiatric symptoms.
I think we have run out of time. Thank you so much, Dr. Gasper, for your presentation today on cannabis use disorder. We will be sending out later to participants a recording of today's webinar. If you have questions on managing cannabis use disorder, I know we weren't able to get to all of our questions, please feel free to contact our substance use one line. You may end up actually speaking with Dr. Gasper. Our phone number is up front and center. You can also submit questions online by visiting our website. We wish everyone a great day and a great week. Thank you for joining us today.
Yeah.